welcome to everyone in attendance, including our guests from the NHS. My name is Councillor Ruth Milsom. I'm the chair of this Health Scrutiny SubCommittee, and just before we start, I will give a few housekeeping arrangements. Can I request that mobile telephones and other such equipment are switched to silent mode so as not to disturb the conduct of the meeting? There is no fire test planned for today. If there is an emergency evacuation, please take instruction from council staff present, and the assembly point is in Tudor Square. The meeting today is open to the public and will be streamed live and for subsequent broadcast via the council's website. You should be aware that the council is a data controller under the Data Protection Act. Data collected during this webcast will be retained in accordance with the council's published policy. By entering the meeting room, you are consenting to be filmed and to the possible use of those images and sound recordings for webcasting. So can I please ask that members and officers in attendance introduce themselves, and we'll start on my left.
Good morning, Councillor McClean, member for Walkley Ward.
Councillor Mary Lee, Councillor for Darnell Ward.
Good morning, my name's Dianne Hurst. I'm an elected member from Richmond Ward.
Councillor Mick Rooney, Councillor for Woodhouse Ward.
Councillor Whitaker, Councillor for West Ecclesfield Ward.
Good morning, Councillor Steve Ayres, Councillor for Grace Park Ward and Deputy Chair of the Health Scrutiny SubCommittee.
Morning, Councillor Sophie Thornton, Councillor for Beechworth and Greenall Ward.
Good morning, Councillor Martin Phipps, Councillor for City Ward and Green Spokesperson for the committee.
Thank you. And we have officers present to support the meeting this morning.
John Cooper, Democratic Services.
Good morning, everybody. I'm Laurie Brennan. I'm Head of Policy and Partnerships, and I'm standing in for Glen today, who's unwell.
Thank you very much. Right, so apologies for absence. We've had apologies from Councillor Basharat with Councillor Lee substituting this morning. We've also had apologies, as Laurie said, from Deborah Glen, Policy Support Officer, and from Lucy Davis, our co-opted member from Health Watch. There are no items this morning that require the exclusion of the public or press, and finally, declarations of interest. Do any members have any declarations of interest relating to any items on the agenda today? None? Right, we go on to item 4, which is minutes of the previous meeting. Give members a moment just to reappraise themselves of the draft minutes. Any issues with the minutes? Are we happy? I think I'm just going to point to item 9, and that's at the end. The committee noted the update to the end of life and bereavement service, but we also agreed to send our comments in via the form that had been supplied to us by the people who attended to receive our feedback, and that's what they presented to us.
Okay.
Thank you. Okay. Do we have any public questions or petitions this morning?
No.
None. And are there any members' questions? None.
None that have been submitted.
Okay. Right. So on to our first substantial item, which is item 7, changes to scrutiny statutory referral powers. And we're going to hear from Laurie Brennan this morning. Thanks for stepping in, Laurie.
Good morning, everybody. Thank you for that. This is a piece of regulation change to the local authority, public health and wellbeing boards and health scrutiny regulations from 2013, which have been sort of trailed for some time, but it really was implemented on the 31st of January this year. So what I've just distributed, and members should have in their packs, is a summary guide from the Centre for Governance and Scrutiny, which, if you look at page 1 of that paper, really really outlines what the government have done to the regulations around this. I've asked colleagues in Democratic Service, that paper's a public paper and it's published online, but we'll add it to the agenda so that citizens can see this as well. It's available online if you search for it, but we'll make it available there. And the government have also updated their own regulations, so we can put the link to the government's material on that as well. So what does it do? In a very shorthand way, effectively gives the Secretary of State the power to intervene in NHS service reconfigurations. The responsible NHS provider has to notify the Secretary of State of any substantial reconfigurations that are taking place, and they also have to send the proposals to the local authority as well as part of that piece of work. What that means is the Health Scrutiny Committee, which is this committee in our case, or the Joint Health Scrutiny Committee, which we have for South Yorkshire, must still be consulted as appropriate. So it doesn't lose our role in that sort of service configuration. We'll still be consulted and asked as part of that calling that the Secretary of State can exercise. The big difference here is that we cannot directly refer reconfigurations to the Secretary of State under our scrutiny duties. Instead, we can ask the Secretary of State to use their power, but it's only asking the Secretary of State and not directly referring. Now, if you look on that in that briefing note, it just outlines what the steps might be, and just to make it kind of pretty plain, really, I think what we'd expect is if there's a service reconfiguration taking place in South Yorkshire, let's say the ICB or the teaching hospital would send proposals to the Secretary of State and to ourselves as well, and Health Scrutiny could ask the Secretary of State to use their powers, but we can't refer it. But the rest of the scrutiny process that would follow, should the Secretary of State choose to use their powers, would remain the same, I think, from my reading of it. I'll pause there, because the rest of the note really just is about the wider regulations for health scrutiny, which I'm sure you're all familiar with anyway. It's really the specific substantive change. The only other thing to add is that as a result of this, we'll update our constitution as well to reflect. So Article 7 of our constitution will get amended to reflect our revised scrutiny duties as part of Sheffield City Council scrutiny responsibilities around health. Thanks.
Thank you, Laurie. Are there any questions about that report? Councillor Hurst.
Yes, thank you for that, Laurie. So in the actual operation of this committee, because there have been issues that we've raised in the past that have been important, does it make any material difference to the changes that we can bring about?
Thank you. I mean, fundamentally, this is that if there was a significant service reconfiguration happening in Sheffield or in South Yorkshire that had been proposed, we could hear a voice from Health Watch or VCF partners, for example, and choose to then refer that to the Secretary of State. As in previously, we can't do that anymore. We could ask the Secretary of State to look at it, but that doesn't guarantee the Secretary of State will use their powers of calling around it. And if you read the government's regulations, which again we'll make sure we publish on the website, but they are public anyway, it suggests that the Secretary of State will probably be reluctant to use these in all circumstances. I'm not saying that's guaranteed, but it does imply that it'll be more used in extreme, I think.
So just to check, because it's early in the morning and it was a hard day yesterday. It's a dilution of the referral powers of this organisation, and it places more emphasis on the fact that we need to work in partnership to bring about any changes that we need. Okay.
I think that's a good analysis. Councillor Harris.
Yeah, and I do recall that when the legislation was passing through Parliament, that there was quite some opposition to the relaxing of the scrutiny powers to refer issues to the Secretary of State. I'm just wondering, I don't recall that we have actually used those powers. I just wanted to clarify that. And but the power was there. Sort of a deterrent, I guess, nuclear deterrent. Should we have the necessity to do that? So I just wondered whether, have we actually sort of got near to referring an issue to the Secretary of State? I don't recall myself that happening.
I think to my recollection, the reconfiguration proposals around minor injuries and walking came close. But yeah, I think it's testament to the fact that we have a good working relationship with the NHS locally, that we're able to discuss things and not have to get that far. Councillor Rooney.
I think the referral that was made was to do with the reorganisation of heart services, but that was done at a regional scrutiny level rather than the council level. But there has been one that we've referred, and I cannot for the life of me remember it.
I was going to defer to Councillor Rooney because he's probably got a better memory than me on this. No, well, perhaps what we'll do, Councillor Ayres, in response is we'll check, because obviously the health scrutiny duties existed before we changed the committee system. This committee hasn't done that in its current guise. Under health scrutiny, as previously operated, let's check. But it's probably worth recognising if we haven't used those duties. But I think your analysis is pretty accurate, really, in terms of what's changed. It doesn't mean to say that. I think one of the things we would need to do, and I think it probably links to a later item on the agenda as well, is to think about how we work together with local community voice of the VCF sector, the local health watch, but also our relationship with the ICB and NHS providers to think about that forward plan of any reconfiguration they're undertaking or any significant change they're undertaking. So we've got a heads up on what that looks like, and I know that's not always easy. But it is useful for us to have an opportunity to coordinate citizen voice and community voice around anything that might be significant and engage the Secretary of State in that.
I can give you a rough idea of when it was, because Lansbury was the Secretary of State for Health at the time. You know, the man that gave us the reorganisation of electricity and railways and things like that. It was Lansbury.
Thanks, Mick. Councillor Phipps.
Thanks, Chair. I just wanted to make a quick comment that I think probably the committee agrees with, that it's really disappointing to see this and to have our ability to refer issues to the Secretary of State watered down. I mean, whether we've used it or not, like the Chair's raised, we definitely did set out that it was an option to refer to Secretary of State when the proposals came to shut the walk-in and shut the minor injury unit and relocate that, restructure it. And it's hard to say how that would have gone if we weren't able to put across our firm position. So I think it's really disappointing to see this.
I think I'm inclined to agree, and I think just thinking locally more in the area as well, not in South Yorkshire but West Yorkshire, the quite well-known, it's quite a high-profile campaign to prevent the closure of Huddersfield Royal Infirmary and relocation of that to a new building without an A&E. And that's precisely the sort of large change that really worries people. And that's what scrutiny's for, isn't it? And I think they did actually refer to the Secretary of State there, and the proposals have, to my knowledge, been dropped some time ago. So it has been used effectively. I think disappointing as well, because I think with the ICS taking on statutory powers and coincidentally us moving to a committee system, roughly, in the same sort of time span, we've got great opportunities to bring everything much closer to home. And, ICSs could be about you know, much more involvement of the public voice and members' voices. And this is a retrograde step, isn't it, really? But as I say, we have our good relationships with the NHS locally, so hopefully we can eschew any negative effects of this and continue working together. Councillor Lee.
Yeah, I was just wondering on the bullet point where it said NHS commissioners will have an obligation to notify the Secretary of State of reconfigurations of services. Does that mean that this current government then has an opportunity to direct local providers, local services to give contracts to private providers? Is that some of the thinking behind that?
I couldn't say for sure on that. I think probably what that implies is any significant reconfigurations automatically have to go to the Secretary of State to view, and at that point the Secretary of State can choose to use that referral power, I guess can choose to use their calling power if there's something they're concerned about. Similarly, they would have to, the commissioning body would also have to refer them to us as well as a statutory consultee as part of that. But I think the implication is that the Secretary of State can take a view on those proposals, whether it's actually intervening in the commissioning process. I think that's maybe slightly separate, I think.
So I do note as well in the on page 8 of this report that there's mention of a memorandum of understanding with local providers and commissioners, and it says here to provide certainty both on activity around reconfiguration and on wider health scrutiny. So that might be something that the committee wants to look at in the new municipal year. Are we happy to... oh, sorry, Laurie, go on.
I was just going to, well, I think that's exactly right. I think what we need to do is add to the work plan. There's a piece of work to do around what the implications are of this for Sheffield. And that might roll, we should start that now, but that might roll into the new municipal year. But we need to do that probably by talking to Health Watch colleagues, but also thinking about talking to the ICB about our working relationship as part of this. Because it is important, and we do want to have that citizen and member voice into some of those proposals. So there's a piece of work here to do that partnership development, as well as thinking about the implications of that for our own constitutional responsibilities as well.
Thank you, I agree with that. I think that having a clear escalation kind of policy that works across partners as well is something that we're going to need. Especially if we're looking at big service change, we want to make sure that if we're going to refer something to the Secretary of State, that we're doing it robustly and within the lines of our own constitution and through this as well. So having a clear set out policy would, I think, be quite helpful to make it as clear as possible. So yeah, I agree with you. I think that might be worth adding to the work programme on there.
Thank you. So we're asked to note this update, and we're, I think, agreeing to place on the work programme further consideration of the implications of this and whether the subcommittee next year might want to look into creating a memorandum of understanding. Are we happy with that? Yeah, not great. Okay, right now then we're on to item 8, which is an update on the relocation of step-down services. And this is an item that goes back some time for this committee. I'm not sure if it goes back before this committee. But I think we are taking this as a closing report to a piece of work that's gone on for some time. So I want to say, first of all, that we're grateful for all the times that NHS colleagues have come and presented to us and given us your time. It's kept us very well informed about this. So looking forward to hearing your final presentation and where you've got to now with the service. So if you'd like to introduce yourselves and give your presentation, thank you.
I'm Richard Bullman, Head of Service for Acute and Community Services.
I'm Gemma Robinson and I'm the General Manager for the acute wards at Sheffield Health and Social Care and Beach.
And Gemma's going to just give a brief update.
Yeah, so I'll do the update. So this is the closing report. To note that Beach is for people that aren't aware, is a 10-bed residential step-down for service users from the acute wards at Sheffield Health and Social Care. The last report provided was June 2022, and that was the plan to relocate the service. I'm not sure if there's been an interim report since, but and then we moved on July 2022 when that was agreed and supported by the committee. So the reason and purpose for the move was around improving facilities for service users and to create a step-down service that provided a safe space. The previous environment was quite poor, and we had an empty facility within SHSC that we could use and support service users to remain with SHSC and still have that step-down care. So overall, the change has been positively received. We've had 15 staff members support feedback and 21 service users, and predominantly positive feedback around the environment, the reduced length of stay, IPC, so infection control. The unit's been really good, and co-location with other services, so supporting service user engagement with other service users on site, and opportunity to offer more to service users in relation to the environmental side of it. So access to service, there have been 127 discharges from Beach since January 2022, so that's really positive, and only 22 of those have actually come back into the acute service, so I think that's really, really positive, and shows how beneficial Beach is to Sheffield. So yeah, really, really, really good. And actually, to support that, we've also had a significant decrease in our length of stay by 10 bed nights since it relocated, so that again is really, really positive. So service user feedback, predominantly service users strongly agree, so they feel that they're supported around their goals, that their needs are supported, there's plenty of activities, the kitchen facilities are brilliant, and there's enough suitable place for visitors, which is talked about throughout the report, that service users feel it's a really positive space, lots of it, and that people can come to visit them whenever they like, and they've got that private space to have them visit, so that's really, really good, including outside space as well. It talks about that. So I have implemented graphs into this particular report just to break down and demonstrate what service users are feeding back, and staff, so they feel that there's plenty of light, lots of space, good sized lounges, meaningful activities and interactions, which we know is really important for people to make a good recovery, so that's really, really good. And availability of those activities is reported to be good. One of the areas that we fall down on slightly is around the office and administration facilities for staff. We know that that's perhaps not as the space is not as adequate as we'd like, so I think our review part of this will be to look at maybe expanding that space slightly. Any impacts that have arisen, I've reviewed all the impacts pre-move, so the impact on care, standard of accommodation, reduction on the one bed, new location and access, and none of those seem to have been impacted since the last report, so that's really positive. And lesson learned, there's a staff consultation that went ahead, nothing's changed since then. We continue to engage with staff, involve corporate services, and continue to support our legislative registration with the CQC. There's been no complaints since the last report either. Is there anything you want to add?
I suppose just in terms of while staff are talking about the issues about the quality of some of the provisions for them, it's a much improved provision to what it was beforehand. So we want to make it even better if we can. And just about reiterating that point about when people are in Beach, they're not on hospital acute wards. So it's just in terms of that's a much better patient experience. It's better value for public money in terms of people aren't on expensive acute inpatient wards, and it's closer to the community, and so it's a really good provision of service. I mean, I think one of the asks is what was there any ask from us from you as a committee? I suppose is I think this is a really good service. We're working with officers in the council about other alternatives to hospital placements, because we still have some people in hospital who could benefit for this sort of service. And Deborah talked about the really positive work we've done about reducing length of stay in Beach, which means other people can access the service. We'll continue to do that work in terms of length of stay on Beach and making sure people get back to their homes and their communities as soon as possible. But I suspect we could probably use more of these beds if we had more of these beds. So I think it's a real success story in terms of the move, in terms of the patient experience, but also the provision of this as an alternative to hospital provision over a number of years. I think it used to be in Wainwright Crescent, which we moved to this sort of provision probably about 10 years ago, and I think it's over that period of time it's been a real success in terms of how it's been used.
Thank you very much indeed. We'll take questions. I've got Councillor Rooney then and Councillor Whitaker.
Hello, Richard. How are you doing? It was what you said about if we had more of these beds, we would use more of these beds. So what's the problem? Why haven't we got more of these beds? And who or what is stopping us from having them?
I suppose in terms of having more access to this sort of beds, it's a resource issue. So,
I mean, they actually save money, do they not, in terms of the cost of an acute bed? And from memory, we were trying many years ago to reduce reliance on acute beds anyway. So I'm just puzzled as to why that hasn't progressed. And from what I'm reading here, this sounds like a very sensible move for a whole list of reasons. So where's the blockage?
I think in terms of the blockage is that would to release money from other bits of the system is difficult. So in terms of having more resource into this, I don't think it's quite as simple as saying we'd reduce our inpatient beds to do that, which would be one alternative. But we've already, I think the number of acute inpatient beds we've got would be very difficult to reduce.
Yeah.
Councillor Whitaker.
Firstly, thank you for the report. It's a really good report, very detailed. It was really good to read it. And the facility does sound excellent, and it's just a pity that we don't have more facilities like that in the city, because they clearly make a difference to people's lives who are coming out of hospital and they get that sort of in-between bit before going back to normal life, if you like. So thank you very much, really good. And it's really nice to have a report come here that's so positive. You know, quite often things are not right, or, you know, we've got members of the public asking questions, raising issues where things are not right. So it's really, really refreshing to have a report that comes along and it's full of positive things. So thank you very much for that. Thank you.
Councillor Hurst.
Thank you, Chair. Very brief comment. This seems very, very positive, and it looks as if you've conducted the process in a way you've moved with staff and service users, which is extremely positive. This might be a dumb question, but Mick always used to say to me, there's no such thing as a dumb question, so I will ask it anyway. Do you think that the improved recovery time or the reduced stay is due to the new facilities, the fact that they are more enriching and allow people's, to get out of the I'm in hospital and I'm afraid what's going to happen mindset, and due to the fact that people have their own rooms so there's improved infection control, or is it something, you just had a good run?
I think it's a collection of those things. I think we know that Beach has got a really good retention rate of staff, so they don't have a high turnover of staff. I think what you find as somebody that's worked on wards and in different environments as a nurse myself, I think when you work in a positive environment, I think, and a new environment and a maintained environment, that gives you a more positive aspect at work. You wonder if that has a link to it. I think, yes, the environment does have a link to it outside as well. I think it's a free space. I think it encourages, because of, we have got the minibus now, which has eradicated the issue around the changing bus route, but I think what that's probably supported is people to take an extra step to access different transport arrangements, and all these breaking down these boundaries has actually probably increased that independence and people reintegrating back into the community. So there could be some of it that's just, that could be by chance, I suppose, but I think some of it probably is the environment, the staff being happier, service users being happier there, and feeling that it's a more engaging environment.
I was just going to add as well, I think in terms of that idea of capital investment in buildings makes a real difference to how we can deliver quality of care. I think in all health settings, particularly in mental health settings, and healthcare and mental health care struggle to get access to that capital money.
Thank you very much. Really positive.
From Councillor Phipps and then Councillor Lee.
Thanks, Chair. Just a quick comment. Just wanted to feedback. Relocation sounds really positive. Thanks for the report and for everyone's excellent work at Beach. And I just wanted to reflect that in the pre-meetings we were talking about, it's not often you get positive news stories, like Anne said, so it's really good to hear. And it was also good to hear, I know there was one issue kind of raised in this report around staff space, and it's also good to hear that that's being looked at as well. So thank you very much. Sounds like excellent work. Thanks.
Councillor Lee.
Thanks. It's a question about those people who have gone through the unit and gone back out into the community again. Have you had time to assess how successful that transition has been once they're in the community, back at home or wherever they've been discharged to? Have you had any time to assess what impact this service has had on success in the community following discharge?
I don't think we've captured the feedback once people have been discharged, if I'm being honest, but from you saying that, I don't think that is a bad idea, and I think maybe we need to take that back. I think what we would measure it on, what we've probably measured it on, is the people coming back into the acute system. So that's a measure of some degree, because if somebody deteriorated, they would come back into the system. So we understand that a very small percentage have at 22, but I think there is something around that follow-up post-leaving, and often because of the stage that somebody's at, they may not have interaction with community teams because they may not need that. So I suppose because we're not having that interaction, that's probably where that falls. But I don't think there's anything wrong with seeking that and asking people if they're happy for us to follow up. I don't think that's a bad idea at all, so we can take that back. That's really good.
Sorry. I'm sure that's what you would want to aim for anyway. You know, it's a good service, very positive service, and I agree with you when you said positive attitudes go, you know, it's very hard to quantify that, but it does certainly help with rehabilitation and the whole treatment package that somebody might receive once they're in hospital, in any kind of hospital setting, whether it's you know, medical or mental health services as well, and that can go a long way to establish people's confidence in themselves and being successful once they've been discharged. And it just means success in terms of a normal everyday life, you know, no great big things, just being successful and comfortable.
Thank you.
Councillor Thornton.
Thank you. I'd like to echo the comments from others about how this is a very good report, and I'm really pleased to see that it's working so well. And as Councillor Hurst said, that you're moving with staff and taking them as a really big part of this. So it's not done to people, but with people. I think that's really important. My question is broadly, because as Councillor Rooney has said, this is a more cost-effective way of doing things, and we've, both from a council side and as a health side, been trying to tackle issues with discharge and making sure that that's a timely process. I know from personal experience elsewhere in the country that where family members have been stepped down from acute wards to more community-based settings, it has worked, and it's like, you know, the staff are amazing, and it just works better for the needs that they had at the time. So I think we'd be pleased to see this rolled out elsewhere. And is there going to be a plan for that in other places? I know that you said, Richard, that there's challenges with resource, but if this is a more cost-effective way of doing things, and I think it does fit into the wider work that's been going on around discharge, that this is a model to follow. And if we're going to use it as an example, we'd love to get an update to see if that goes forward elsewhere, really.
Yeah, I think in terms of where people get admitted to hospital, it's the most expensive use of our resources. It's a use of our resources which is detaining people's freedom. So we don't want to admit people to hospital unless we absolutely have to. Our bed base in Sheffield is, I think we'd struggle to reduce our bed base further than it is at the moment. And over the years, we have looked at what alternatives there is to stopping people getting into hospital. So we've had big investment in crisis resolution, home treatment services, which is at the front end of the door to mean that we can intervene with people at home. We will still need a number of people who will need to get admitted to hospital. And this is one of those avenues we've got in terms of once somebody's ready for discharge and various bits of the home aren't ready to move to, or they need to move to a different type of residential care or nursing home care, this is a better place to have people. And we've set up things like the decisions unit, which is another alternative to hospital admission. So we've got a strong emphasis on getting our alternative to hospitals as good as possible. I think if we did have a big amount of investment in services, what we'd want to be looking at doing is making sure our inpatient environment is as good as possible. So once people get into hospital, they have as short an admission as possible. So that's the right staffing of the right skills, so we can do the right therapeutic interventions. But then when people are ready to be discharged, we've got a different series of alternatives. The council and the ICS has recently set up 3 additional beds, which is with one of the voluntary sector or third sector partners, which is doing that. Those 3 beds we set up, that they started about 3 weeks ago. We've got people into those beds. So that's evidence of where we'd want to do more of that going forward. And I think we're always searching for additional investment to get into services and alternative this. I don't think it's a controversial thing to say that mental health services isn't invested as it should be. I think the government report, No Health Without Mental Health, identified that the burden of illness is 24% for mental health, and the funding that goes into it is 11%. So that's an impossible ask to say that we'd double our investment in mental health services, but that's what the government has said in terms of what needs to be invested in mental health services. If we had that sort of scale of investment, we would definitely want to be investing in more things like this.
Sorry.
I've forgotten how many hands are up now. I think Councillor Rooney had indicated. Can anyone else indicate just at this point? You had. Steve, are you also?
No, just to echo the.
So we'll take Councillor Rooney and Councillor Hurst, and then Councillor Ellis. Sorry, my fault.
What I'm hearing is a very, very good reason, or series of reasons why we should be investing more in this particular type of service, and particularly in view of what you said. I think that the acute bed situation is at capacity. I've always believed that, I used to sit where Ruth is sat now many years ago, and I always believed that when someone came to a scrutiny board, we should send them away with something to do. Richard. But there is also an element of policy development in scrutiny committees. It's not just about, checking whether or not you've been good boys and girls over the last 12 months or whatever. It's about trying to point you in the direction of travel that politicians would like a particular service to go. And I just think we should find a wording, some form of wording that says we would like what you've described this morning, Richard, to be pursued by whoever it needs to be pursued by in the future. And I think that sort of links with what we were talking about the other morning, Ruth, about what we would like to see happen over the next 12 months. It's about policy development and grasping what we believe is an excellent service and expanding it wherever we can. So I just want somebody to put that into words that people can understand if everybody's agreeable.
I think I can come in here, Ruth, because that's what I was going to say. How do we champion this? How do we publicise this? How do we get the good news out there and encourage more developments in the same way?
I think we're all repeating ourselves here. Yes, I think how do we promote this? But also, I suppose there is a question in there is how do you think that we as a local authority can assist? I mean, given that we're strapped for resources ourselves. Other than that, how do you think that we can expand the good practice that is obviously here in promoting more beds, for example? Have you any thoughts on how we can support that? But I do support what Mick is suggesting. That was really my main point.
You're looking at me there, Gemma.
Well, I don't know the answer. No, I think it's the resource of the environment, isn't it? I think we know that if we had the space, actually the cost of staffing something like Beach is actually less than that of an acute ward, because they don't have to have registered nurses. So we know that. So that's one thing. So it's a registered manager, CQC manager, who oversees it, but the rest of the staff are band 3 staff. So they're healthcare assistant, support worker level. And because it doesn't require a registered nurse on. So actually from a staffing provision, it is also a more cost effective, because people are at the part of the journey where they need a registered nurse. So they're on that road to recovery. So I think it's, for me, I don't think the struggle would be staffing it as such. I think it would it's the resource to the beds, to where to put the beds, because we haven't got any more provision within the organisation right now. So where would that be?
Sorry to interrupt you. Would capital investment in the facility that you're vacating help solve that problem in any way, shape or form? I mean, I know where it is, but I don't know whether that's a sensible suggestion. Capital investment.
I think I've done what's happened to that building subsequent to us leaving the building. I think the only thing I'd say with this is that it's within a system. Is how do we invest any new money we've got as wisely as possible? And I think sort of one of the dilemmas is do we invest at this end of where people are being discharged from the hospitals, and that's good value doing that because it's better value and it's a better patient experience. I mean, being in a hospital ward, if you don't need to be in a hospital ward, if you need to be in a hospital ward, that's exactly the right environment, and we're going to make those environments as good as possible. But the flip side of it is we also want to stop people needing to get into a hospital. So when there's a scarce resource to invest, is whoever is making the decisions about that scarce resource that's being invested, we also need to consider what things can we do to stop people getting into a hospital. So there's I think there's a discussion we need to have an ongoing basis about how any new investment is spent to make sure that we're sort of meaning that people are treated as close to home as possible to stop them getting into hospital. That's the ideal scenario. And we are looking at, there's a whole agenda about how we're working with primary care, about community transformation and primary care mental health transformation that's going on at the moment, which is really good. So I think that it's one of the things I think we need to have some thought about how best we use what resources we have. I think this is a really good use of resource.
I think it's slightly sort of scary hearing you say, what do we need to do more in terms of preventing hospital admissions? Because I'm presuming that the figures don't lie, and there are an awful lot of people waiting for assessments and treatments. And I wonder to what extent, without wanting to cast anything negative on what's been a really positive journey for you, to what extent are people sort of being forced into a loop of crisis, acute admission, step down, back into the community setting, because they can't access the more life-changing care that they need. So are you, to some extent, a sort of, a stopgap, a holding pattern, if you like? And are there people who really ought to be accessing another form of care rather than going around that cycle of admission?
So we don't want people going through a cycle of admission, and I think the provision we have once people get into acute care is there's a lot goes on within that environment to mean that that's not just having a cycle of admission and giving people active treatment and giving them appropriate plans to go forward once they're in the community. That's a really difficult question. So no, it's a good question. It's yeah.
It's just, I mean, there are people, aren't there, who are readmitted periodically, and I'm sure you know, the staff at Beach probably expect to see some of the same people, you know, come back again. And I mean, do you see that as a bad thing? Is that, I mean, if that's what keeps somebody in relative stability in their life, is when they, you know, when they reach crisis, they know that they've got that step down facility to help them get back to normality again. Is that okay? Do you treat that as okay, or is there like an underlying objective to have these sort of readmission numbers down to 0?
I mean, I think from my perspective, I think we have service users that, exactly as you've just said, that the pattern they follow is that they become well for a period of time, and that then they know they may enter back into an acute service, whether that's through a community team or straight back into the acute service, and that's their pattern. It's part of their care plan, and we know that. We're not always going to be able to prevent that happening, because that's what somebody needs, and we have to recognise that. What we have done is, going back to the point Richard made, put services in such as the DU to try and bridge those crisis points to catch that first, and to see if we can support imminently. And that's why there's lots of work going on with A&E and 111 to support and capture people before they reach that crisis point. But ultimately we will always have people that will follow that pattern, and that's a recognised pattern. It may be that the people that were readmitted out of the 22, that they don't go back to Beach, because that may not be felt that's the right step for them out, and there could be other opportunities. So I think it'd probably be interesting to understand the journey those 22 people took that came back into the queue, whether they went back through Beach actually, or whether they took a different direction out of services. But I think, yeah, in answer to that, I think each service user, as you know, they're all individual, they all need individual care, and that's what we try to achieve, to provide that. So it'll be very dependent on that person and what they need at that time.
And I think it's really important we as a system and a mental health trust don't see anybody who's been readmitted as a failure.
No.
So I think that's probably inevitable to happen, and you know, it's appropriate that we support. Our aim is for everybody to work down a recovery route, or what recovery means for that individual.
And when you're here, so I'm going to indulge myself a bit longer, get rid of my questions. When you hear people's stories, when they're in the step down service for the first time, and you hear their story, how they come to that point, are there other factors within NHS services, so from primary care to whatever, are there other factors that are contributing to someone reaching crisis? And I'm asking that question thinking very much of a person who reached out to me in my ward, who has been waiting for various medical interventions, so assessments and possible treatments, but the waiting and other circumstances in their life that could perhaps have been, they could have had a lot of early help to control those, is actually leading them into a crisis situation in mental health. So they've got physical conditions that need attention, but they're on very long waiting lists, and also waiting for some psychiatric help already. But I think that person's going to end up in the acute ward because of the other circumstances, which are actually all in the control of the NHS as well. So it's, you know, I know it's not as simple as just one bit talking to another, because it's all about where resources are, but what are your reflections on that?
I think we do have people who are waiting for treatment, and it would be better if they weren't waiting for treatment and we were able to access that. We have a lot of systems in place to try and ensure that we identify the resources to go to the people most in need. So how we've organised our services is to focus our efforts on those people with the most serious needs to try and stop them getting to that position. So we have developed things like, as I talked about, our crisis resolution teams, but also our community mental health teams, which have been through a transformation to try and sort of ensure that we can deliver the services as effectively as possible there to stop that happening. And I think I think there's two challenges always with that, is how can we make our services as efficient and effective as possible, and then is what would we do if we had some additional resource to do that. And I think there's probably capacity with both. If we had more investment, we would use it very wisely, and I think the investment we have used has been very wisely used. And we also are permanently seeking about how we can make our services more effective. And I think this is an example of something that we've had some investment, we've managed to make it more effective. The only difficulty, I'd say, if you had anybody from any of our healthcare systems, they'd all be saying, can we have some more resource into the services?
Thank you. I just want one more little comment, which is that on your report you've included a photograph of the sort of seating area in the facility. And I want to say Councillor Mary Lee and I visited the facility. I forget when it was. I think it had been open about 6 months. And that photo, I have to say, is genuinely a reflection of what we saw, I think. It's an extremely pleasant setting, and I found it really encouraging to step into, and very calm, and the sort of place that would be very encouraging to service users who find themselves there, to set them on the next bit of their journey. So, sometimes a photograph might just be very cleverly taken, like estate agents, to show the very best of something. But I think that is a fair reflection of what we saw, and it really was quite impressive. So thank you, Councillor Lee.
Yeah, no, I'd agree with that. It was a lovely, calm setting. Obviously, it was new, it was brand new, and it had been refurbished, and so that was really nice. So I suppose what I'd say about that is, have you got the budget to replenish those furnishings when they need replenishing? Because that's important that you have that earmarked as well. But that wasn't what I was going to say. I guess it's about what you said about community care, and the vast majority of people who've got any kind of mental health problem will never need an acute setting at all. A small proportion will need that at some point, and maybe there's a sort of revolving door still occurs, and some people will need to go here and some people go home. But I guess it is, what can we do? We know there's evidence out there about what will help people stay well and what will help people recover in the community. I suppose that's the issue, is the resource that evidence says we need to make sure that happens. And it's about ensuring people, when they've been ill, recover their resilience, because we know a lot of people with acute mental illness are so sensitive to stress. And stress is everywhere, and it's quite normal to some degree, but some people are more sensitive than others, and we need that resource in the community, as well as in a setting like this, which is really good.
I just wanted to touch on the fact that I know we're talking about waiting lists and people waiting for access to services, and the organisation have actually heavily invested from a QI perspective into waiting lists and waiting well. So this is a piece of work that we're doing at the minute to understand what people need while they're in that period of waiting for services. So that's quite a new piece of work, and we're hoping to see some significant changes from that, and all the services attend. So we had the QI event the other day for flow.
Quality improvement.
Quality improvement, yeah. So that was around flow, and all the services attended, and it's about working together to understand where are those sticking points and how can we support people. So I think we acknowledge that we need to do more, but actually what we need to do is understand what we can do about it and what teams have we got to support that. So I think it's part of all the transformational work, but I think that's just important to note that there has been that investment from a quality improvement perspective and that specific set of skills applied to this. So I think that for me is really encouraging, that we're trying to do that. So yeah, I think it was just important to feed that back.
Are there any other questions or comments? Just going to take a moment just to think about how we pick Councillor Rooney's and other people's suggestions of what action we might be talking about. Just give me a moment. Laurie will just make a suggestion for us.
Thank you, Chair. I'm just trying to pick up, I thought I was going to get feedback there. Trying to pick up Councillor Rooney's point around how we take some proactive action on this. I think one of the things we could do as a committee and through the Chair is to write a letter to the ICB as a sort of recognition of the work you've put into, one, the service, but obviously two, coming here and giving us such a glowing report about the impact that your work is having on service users and ultimately the impact that has on acute services in the city as well. So it's a really good case study for showing that sort of, I think the phrase ranges, but it's sort of left shift and moving out of sort of like towards preventative intervention. The second thing is there's a big piece of work going on at the minute which is being led collectively with the health sector around the new joint health and wellbeing strategy for the city, which is the statutory strategy we have to have for Sheffield. It's a really good example of that sort of mentality of moving towards tackling some of the more acute demand in the system as well. So I think there's something we should do in terms of submitting it as a sort of example of that, and I can certainly support that as well. So I think I can pick that up. And then the last point, maybe there's something here about how we maybe promote this a little bit and talk publicly about this is a really good example, and maybe we can do that alongside some of our commissioning teams as well. So we can pick that up as well. So we'll make sure we reflect that in the recommendations from the committee today.
I say all that, really.
Word for word, yeah.
Can we just make sure also this positive feedback gets from here, gets back to the staff, because I think they need that. They need to know they're doing so well, yeah.
So I think we tell the staff anyway, and I think this will be really good for them. I think this will be really positive. What I would say is we did have a board visit the other day, and that went really well. We've had very similar feedback, but one of the areas we acknowledged is that do we celebrate this service enough? And at times what we do know is that, as we've discussed today, that the acute system can be quite powerful and can often overshadow, and we don't want that to happen anymore. So what we're saying is actually we need to promote this more, so more comms. We have a couple of service users going to board to do their story of their experience, and I think that's been acknowledged for us as well. So I think, yeah, we'll definitely make sure the feedback comes back to them. But yeah, it's just nice to know it's been well received.
And Gemma, the long-standing manager unit's retiring very shortly,
yes.
So we'll have an opportunity to go and sort of speak at her retirement do. And I'll make sure that we mention the sort of the feedback from the council with that to Tracy and to the whole team. And we're very excited we've got another good manager who's coming to replace Tracy's role.
After 33 years to the NHS, so yes, very impressive.
So I've got that the action of the subcommittee from today's discussion would be to write a letter to the ICB highlighting the positive work that's been done in terms of relocating the service, how you manage the staff and user service user consultation at the early stages of that, and the successes of the new facility at Beach, and that we would like that positive feedback from what you've given us in the update today, how pleased we are with that situation, and we'd like that to come back to staff as an encouragement to them, and that we would like to include members' thoughts about the value of the service and how it might be developed in the future to perhaps provide more capacity in the non-acute setting. Does that reflect what members have said? Is there anything else? Does that sound okay? Is that an agreed action? Lovely. Thank you ever so much for your time today. And it's
just the Chair, just the health and wellbeing. Do we need to note that the strategy? Laurie also referred to the developing health and wellbeing strategy in the board. The strategy that's going to be in place for 10 years is going to be fundamental. So I think we should make some reference to this approach, especially following yesterday's workshop, in that strategy. Thank you.
okay, super. I think we're there. So thank you ever so much for coming, and good luck as you carry on. And I hope one day you get even better resources to expand what you're doing and serve even more people. But thank you for everything you do. So, members, we've got the next item, item 9, which is an update on the Continence Services. And there was some work done around this in the December meeting of the committee, which Councillor Ayres kindly chaired, in terms of the end-of-life strategy and that tying up with the Continence Services. And so we've got some unfinished work in this area. Now, unfortunately, we don't have any representatives today from the ICB to present to us on this item. So what I'm going to suggest is that we adjourn the webcast for a while so that we can just appraise where we're at with this piece of work, look back at the history of the recommendations that were made previously to the NHS by a previous incarnation of this committee, and we can have a discussion around where to go next with this so that it doesn't get dropped. Is that acceptable? Okay, so we'll just stop the webcast at this point, if that's okay. Right, welcome back to the meeting of the Health Scrutiny SubCommittee after our brief recess. Our item number 9 on Continence Services on the agenda today has nobody to present to us from the ICB. So my proposal is that the subcommittee takes a brief discussion around where we've reached on this piece of work, which goes back to 2019, when there was a working group set up to scrutinise Continence Services. Referring back to that work, there were some recommendations made by that working group, and they were brought forward to the NHS, the clinical commissioning group as it was then, and those recommendations were accepted by the NHS. And so the normal process is then to receive updates on progress against those recommendations over time. Looking at Steve as a previous chair, I think whether you took any items on that service, but certainly in March 22, there was an informal meeting with the CCG and with Sheffield Teaching Hospitals to discuss their response. And then subsequent to that, the item has remained on the work programme for the previous committee and then this committee, mindful that we need to receive an update. So I think that was something that got delayed several times during last year for various reasons. And eventually there was a form of update in December when Zach McMurray came from the ICB to give a sort of interim update. He did take a lot of questions away still to be answered. Certainly not everything that was asked in that meeting was answered. And he did go away saying that he would pick up a lot of those questions and bring answers forward. So here we are today, and we're not able to obviously interact with the ICB about this. So I wanted to give members the chance to comment about where we're at with this work and what you'd like to see going forward. And then I've got a recommendation for what we do from today's meeting. Any questions or comments? Yeah, Sophie.
Sorry, I wasn't sure if you were looking at me as Steve then. Thank you, Chair. Obviously, I think this is probably a view shared that this is quite disappointing that we've not got someone here. Obviously, Zach McMurray came last time, but he is quite removed from the service, really. And it was good of him to come and try and field questions as best he could, but he wasn't the appropriate person to do so. We're at this point because there isn't progress on the recommendations, and if we're going to go through the recommendations were to consider going out into the community, to consider getting better consistency of messaging and education, to consider how it can resolve tension between medical effectiveness of products and service users who feel that sitting in wet pads compromises their dignity, consider how to address inequalities, stigma, racial inequality, to consider how to get better feedback, to consider incentivising training amongst partners, and to consider how to improve people's discharge experience. This was 3 years ago, whenever. How are we only just here? I mean, we've seen it instead of, it seems like that instead of looking at it differently and only now considering these things, like the service did then make a cut to products on the front line, and we saw from public questions last time that that's had a really detrimental experience on service users and people's experiences. And we don't want people to have to feel like they have to come to us to get their voice heard going down the line. I'm very frustrated by this, and I think that it's, if we're only now considering going out into the community, it's like, what's been going on to improve the service over the last 2 years? Please come and tell us. We want to hear that. We want to hear what's been going on, because if there is a positive thing that we're not aware of, then you need to come and deliver that report to us. It's just incredibly frustrating, and I'm very confused as to how there's not been much progress when the recommendations themselves were quite agreeable, and as you said, were agreed at the time. Yeah, I think that's all I've really got to say about it.
Thanks, Sophie. I think I echo your frustration. And it does need to be the right person, I think, to interact, so that there's no point is there someone who doesn't actually work in close connection with the service. And yes, in December it was quite strongly highlighted, the lack of process, particularly around hospital discharge. And that in that case it was to end-of-life care, wasn't it? Which can be very distressing for families and carers and for the patient themselves. So I think there are items in the recommendations that really I would like to see treated as much more urgent. Any other comments? Yeah, Laura.
Just to echo Councillor Thornton's comments, I've actually been disappointed that nobody's been able to come today. But I also just wanted to mention that I think I had to give my apologies for December's meeting, but I understand when Zach McMurray came that there was a member of the public who came who had some questions. I think that they were going to be answered in writing. I think as a committee we just want to make sure that that member of the public has been responded to. That would be important for me. Thank you.
Just give me 1 second. Yeah. Okay, so the public question that came in December, which was extremely pertinent because it absolutely highlights the lack of progress on discharge and provision of necessary products, and I think right back in the working group time, there were issues there around people having to sort of scrabble around literally in cupboards, in storage cupboards, to try and find incontinence products, because the supply, somehow there's something not happening right in the supply chain and assessment process, and that seems to be at a complete stagnation. Nothing seems to have improved at all around that, and I was really glad that the member of the public was willing to come and actually highlight that in person. It's not a comfortable subject to talk about, so I think we're grateful that they came and actually talked about that openly. That public question, which has not received an answer that we've seen, has been now taken by the ICB as a complaint. So this is my understanding that that's being treated as a complaint, and so we are not part of the response process unless the questioner agrees, they'll have to be asked formally now to share the response that they get with the Scrutiny Committee. So that's the position we're in. So we won't hear an answer to that unless the person who brought the question agrees that it can be shared. So I don't think I find that ideal. Slightly peculiar process, but out of our hands. Councillor Whitaker and then Councillor Hurst.
The December meeting, although, as we've said, Zach McMurray wasn't the right person to do it. I mean, you know, he had a good try at doing it and answering the questions and things. But it was quite difficult to listen to the member of the public who'd come along and shared his story. You know, it was quite a difficult story to listen to, and you kind of felt a lot of empathy that, you know, you wouldn't want that to happen to your family member. I think it was his father-in-law story he was detailing. And it was kind of painted a picture of a system that was clearly not working. And so it is disappointing to think that, you know, that we haven't had any feedback from that, and disappointing that nobody's here, because clearly that leads us to believe then that things haven't changed, things haven't moved on. You know, and from the December meeting, we're now 3 months along the line, and things haven't moved on. And, you know, so we don't know, have things improved since the March 22 report? We just don't know, do we? And it's disappointing, because you think that if things had moved on and there was successes, then they'd be here to tell us about it. And the fact that they're not, you assume that there aren't those successes. So I think it's incredibly disappointing. And I think that lots of people experience this difficulties. Somebody I know works in the community as a care worker, you know, sort of details, things like that, occurring all the time. And it's not right, because it's a difficult subject, and it's, you know, things like the sort of provision of products and things, it should work really, really well, so that it kind of takes away that little bit of a stigma and things. So it's, yeah, disappointing.
Laurie, yeah.
Thank you, Chair. I think I appreciate the members' disappointment around this, and probably share that, I think, as well. I think there's something here about how this fits with the conversation we had previously around the changes to the regs as well, about how we develop as a committee, including into the next municipal year, our relationship with the new NHS infrastructure, because there's been so much change on our side, moving into a committee system. It's a big shift. But also all the NHS infrastructure is very different as well, lots of different personalities and people around that. There is something we should do probably to build that relationship and the mutual ways of working and understanding the strength and the opportunity that this committee in its existence brings. It brings citizen voice, it brings member and democratic voice into looking at local services which are absolutely vital to our community, so that's absolutely right. So there's something maybe I can take away with colleagues from Democratic Services about how we can have that conversation and maybe do something to build the shared knowledge about how we work together that's beyond just this specific item. But there is something here about how we make sure that this isn't lost, that we've got, this is the last meeting of this municipal year, but this should be an item that's on the first one for the next one, certainly, giving the NHS side of colleagues time to put this together in the right way, because an update report, even if it says progress on some things and not on others, is a useful update for this committee to hear and for citizens to hear. So we should pursue that, and I'll take that away as an action as well. And then just the last point is there is an opportunity here, as you did last time, to start linking it to that end-of-life piece as well, because it does make, there's a complementarity to that, and I think there is, as you said, there's sort of a connection with the teams in the NHS side as well on this, so we should take that away as an action, and we'll build that into the work plan as well for the next year.
Thanks, Laurie. Councillor Hurst.
Yes, thank you, Chair. Echo Anne's disappointment, because it was a hard story to hear, particularly as I think my own personal experience with my mother at her end of life, which I think I shared at the time, reflected that. And it's about giving people dignity in circumstances that you can't change, isn't it? And it does reflect a disconnect in the service, that they don't appreciate that maintaining the dignity. The contrast between the two, between the presentation about the service that we've just had that maintains people's dignity and allows them to recover, and this where they there's no change, so we don't have to come and talk to you about it. It's not us. We don't care for us. We care for the people that we are representing. So my thoughts probably ran along Laurie's lines about we need to have one final go at making that link and giving people a chance to respond to that and come back to us. Is it something that we need to look at maintaining dignity in later life in other pieces of work that are coming forward and in their health and well-being? You know, as we're, it's a lesson that we've got to take with us, isn't it? When and look at other things through this lens, when we're developing strategies, and because dignity was spoken about yesterday and came across very, very well in a presentation about developing the new health and wellbeing strategy. And this is a very fundamental, small adjustment they can make to maintain dignity. And is this one of those instances that we would have referred eventually to the Secretary of State? Were we able to? And I'll leave it there.
I think something that has caught my attention in this whole thing is that the supply chain, the NHS supply chain, is used as something of an excuse for delayed delivery of products that people need. I've seen that in several cases, and it was certainly in the case that was brought to our attention in December, and probably in your case as well, Dianne, with your mother. And to me, that is. I'm absolutely sure that that's a factor that our Sheffield and South Yorkshire NHS representatives are not happy with. But I don't know whether this is something to do with different parts of the NHS not working in a joined-up fashion at all, which is ironic, seeing as there's been so much effort spent on integration. So I think that specifically is something that I would want to keep challenging on. That if that is a hole in the service, that is just meaning that the service doesn't work for a whole lot of people. It's just completely unsatisfactory and really needs challenging. And maybe we can be of some support to our NHS colleagues in achieving some change in that. Councillor Rooney.
Try and be brief and hopefully helpful. If this was happening to a member of the public, they would be making an official complaint somewhere, wouldn't they? And I don't think that it's actually an issue that we would refer to the Secretary of State, because there's a very high threshold for that. What my question really is there some sort of mechanism where we can, or should there be some sort of mechanism where we can register the fact that we are unhappy a process with the lack of response by an NHS body to an issue that we've discussed and sent recommendations to them, a sort of halfway house between the two.
I think you're right. It's not probably through that former referral route, certainly, but there are clearly routes locally through our executive structures, and I know that through the chair and the group spokespeople on the committee and the deputy chair, we have made our kind of frustrations and sort of disappointment known to the officers involved already, including more senior people on the NHS side. There's probably more we can do via some of our senior officers here as well, and to articulate that back to the NHS, which is an option probably available to us. We've got to balance that with the willingness and the eagerness to make sure we have that positive relationship with the NHS side for this, because we're all mutual interest is better outcomes for the citizens ultimately, isn't it? So.
I understand that, but that basically relies on conversations between individuals. I'm a great believer in having a paper trail so that you can prove that this was said on such and such a date by such and such person to such and such person. because conversations just get muddled or forgotten or whatever. I'm asking for some sort of process where that sort of issue is logged somewhere and then chased by somebody.
Councillor Ives, did you have a hand? Was that your hand?
Yeah, I suppose that, you know, comment on that. I mean, I'm incredibly disappointed that you know the findings of the working group, which I have to say I wasn't actually a member of the working group, was actually 2 years ago. And I do think that we as a Health Scrutiny SubCommittee under the new committee system that we've adopted since last year should include a recommendation to the ICB that, you know, so that it is recorded as a minute, you know, as a recommendation from this, that this be looked into to consider the length of time from when the working group came up with its recommendations and now, and we still don't have a response to the requests that we've made on several occasions. So I think it's via the ICB that where we need to make a recommendation. That, in my opinion, I will obviously take Laurie's advice on that, but from this meeting today.
I think I'm hearing that as that we might want to refresh the recommendations of that working group, sort of reiterate them, and make a new recommendation that the ICB engages with members of the subcommittee and that they maybe come forward with a plan to expedite action against those recommendations. So that's a specific action that we're asking of the ICB rather than just coming with an update.
Thank you. Just as a quick aside one for us as a committee, I think as Mr Sugars did spend quite a lot of time and clearly, as has been said, to bring us quite a emotive story of his personal experience. It perhaps might be good of us as a committee to write to him following this, just to give him an update on where we are now and the actions that we're taking as a result of this meeting, just so that he's kept up to date with it as well, because I think we did commit at the last committee to keep him updated too. So if that could be formally done, I think that would be great, if others are in agreement.
I think that's a good action. Are people happy with that? So we'll write to Mr Sugars and thank him for what he brought to the committee and update him as to our understanding of where we're at and where we're going to go next. So I think as well we have an action that Laurie's recommending, which I think I agree with, that the subcommittee can partially refer this to Democratic Services to engage with the relevant lead ICB officers so that some ways of working can be explored in parallel to us writing to express our asks as well. Does that seem acceptable?
Yes. Sorry, could I just ask, are we talking about a referral to the parent committee? No.
Right, okay. I think, have we got all that down? I've got that down. Okay, right, great, thank you. Okay, on to the work programme. So obviously this is the last public meeting of the year, but we do have our dentistry workshop forthcoming on the 25th of March. I think that's at 9:30 a.m. So keep your diaries clear. We are inviting members of the public who have responded to the Dentistry Services survey which do keep promoting, by the way. I think we're heading towards 400 responses, and about 180 of those have said that they would be interested in coming to the workshop. So that the workshop will be ticketed by invitation to the people who have responded in that way. And we have various ICB lead officers, so the dentistry commissioning officer, invited to attend. So that is an informal session, but hosted by this subcommittee. So it's kind of our last meeting of the year, I guess, just on the day before the pre-election period starts. So if you want to tweet about it, do it on the same day. So that's that item. Laurie, can I go over to you for the rest of the work programme?
Thank you, Chair. So obviously there are a number of things we've discussed today which that if you turn to page 35 in your packs, there are some items which are outstanding from this year which will be carried forward, which I think members are probably aware of. So the mental health interventions workshop and the primary care workshop for the next year. We're also obviously recommending from the last item around the Continence Services that gets added straight back onto the work plan for and scheduled for the first meeting, whatever when that date for that's confirmed. And then just on the last item there, the end of life care, I know Deborah has been working really hard to try and find some dates for that to happen in April, and that's perfectly viable as long as we've got availability for members in that space as well. So I know she's been working with, I think it's Louise Potter from the NHS to try and arrange that before the May elections. So that'll carry on. The other thing we need to add to the back of the work plan as well is obviously the piece we discussed earlier around the regulations as well, potential MOU and the relationships with the ICB. Thank you, Chair.
Okay, anything else that members would like to bring forward for next year's work programme at this stage?
Is Greg Fell coming to the discussion about dentistry? I know he has some very strong opinions about one particular topic.
I don't think that will be discussed at the workshop. So it's a very targeted workshop. So obviously we've heard from several hundred members of the population in Sheffield about their experiences of accessing dental services. So it's not a policy discussion in any way. It's an opportunity for members of the public to voice their experiences and tell their story and ask questions face to face with our ICB representatives. So if things start heading off into a citywide policy, we will probably curtail that.
Thank you, Chair. I think I appreciate that this has probably been talked about between spokespeople as well, but with the adult autism and neurodevelopmental pathway, as we haven't had a report on that today, I know there's been delays in gathering the information and wanting to make sure that's as comprehensive as possible, just to ensure that that's not forgotten about, as it's not in the items to which we've agreed to set a date for yet, so that we're not just assuming that as it's in the table for this meeting that it's been discussed at this meeting, because yeah, as we'd raised it a few times and it didn't get added to the work programme a few times, so we just wanting to ensure that that gets carried forward and is there.
Yeah, it was supposed to be on today's agenda, wasn't it? And it's been delayed, so that automatically goes on to the next meeting in the new municipal year. Just with the heading, adult.
Adult autism and neurodevelopmental pathway is what it's down as. It was in reference to the SANS SAA-NS service. The ADHD and autism assessment service.
We have had some discussion in briefing about that. If you're interested in being involved in any further briefing discussions, so because I know you've brought this item forward, so apologies that you weren't involved with that, but I keep feeding in because I know you've obviously brought that forward as a particular interest.
Yeah, thank you. Steve does keep me updated as well, so. That's grand. If there's anything that you think is super relevant, then please do pass it forward. But you do keep me updated, so we're all right on there. Fabulous, thank you.
Anything else? Anyone want to bring anything forward for next year? All good? Okay, so just to say that the next formal public meeting of the Health Scrutiny SubCommittee will be held on a date and time to be confirmed, because we enter a hiatus with no future in a week's time. But don't forget the dentistry workshop. Do be there, and you might find some of your constituents there, and hopefully we can have a constructive discussion with the ICB around that. On the same afternoon, I should flag up as well, the afternoon of the same day, we have the joint Health Overview and Scrutiny Committee meeting, and we have asked for a plan for dentistry in South Yorkshire to be brought forward, and we're anticipating something at that committee, so you might want to also take note of that in the afternoon of the 25th. Right, I think that concludes business, so thanks everyone for your attendance and your input, and see you at the workshop.